to be here with all of you. We have some wonderful speakers here. We have, of course, Anurag G, who leads the global outreach at the Stanford Mussallem Center, and he also recently authored the book Reimagining Health, which focuses on how we redesign health systems and build the ecosystems which allow innovation to scale. We have also here with us have Pranav Shrestha, who had co-led and built the Octopi platform at Cephala Inc., working in AI and automated microscopy to make disease detection more accurate in low resource areas. And then lastly, we have Milli, Seth, who is the CEO of the Saloni Heart Foundation, which focuses on building long-term pediatric cardiac health systems. And so with all of that, we will now go ahead and start. I would like to first ask you, Anurag, what is the overall core thesis in your recent book, Reimagining Health, and how do you think we will actually enact the structural changes needed in order to improve overall healthcare systems?
Thank you. Really great to have you as a moderator. It was great to visit India with you and the rest of the 1990 scholars. And as you saw there, the unmet needs are very substantial in India, but that's true across Global South. So there are three key points in the book that I wrote, Reimagining Health. Point number one is that the healthcare system we have today is not a healthcare system, it's a sick care system. We only deal with that system when we are sick. How many of you go to healthcare institutions when you're healthy? You only go there when you're sick. So it's a sick care system, and when you're healthy, the system doesn't care about us. So that's number one. Number two is that the care has moved away from homes and communities into these institutions, so it has become more and more centralized, and outcomes have actually not gotten better. For some of the acute conditions, they've gotten better. For a large majority of the conditions, actually, they've gotten worse. The quality of care and the satisfaction with the care and so on has gone down. And lastly, we still have a substantial gap between Global North and Global South. In Global North, we have reasonable access to care. We spend 18% GDP on healthcare. In Europe, we spend about 10%. India spends 2.5%, 3%. Africa less. And that gap will continue to widen because there's no way Global South can spend at the levels that Global North can. And as Global North starts to age, that burden will worsen and that spend will also not be enough. So what I talked about in the book is really that we are heading towards a crisis. We already are in a crisis in a way. Unless we reimagine our health, not sick care system, not a healthcare system, but health which includes health and well-being of people, mental health, other kinds of well-being at home, near home in the communities, we're not gonna really address the problems of the world, the 8 billion people that exist in the world.
And on that note, actually, that is a good segue into asking you, Milli, how, what was the underlying motivation for launching and building the Saloni Health Foundation, and what are the learning lessons that we have out of that example that may be used in other such efforts to actually expand access to health in these extremely low resource areas?
Thank you, Bob. It's an honor to be on this dais with Dr. Mairal, who also is my guru. Thank you so much for putting this entire and encouraging all these students. They're doing a phenomenal job. This point, once again, we already wished each other Happy Mother's Day to all.
Happy Mother's Day.
Sincere respect, gratitude, and admiration to all the mothers. Saloni Heart Foundation was born to a mother was grieving, to my grief. So to put context, Saloni Heart Foundation was born after we lost our younger daughter, Saloni. She was born with congenital heart disease in India, and little did we know at that time, even after losing her, that 1 out of 100 children are born with heart disease, congenital heart disease. And it's lesser known even in the Western world, which actually translates in terms of disability adjusted years, 18.7 million dailies, which is significant. And when we started Saloni Heart Foundation, our original goal was to provide pro bono second opinion. And like Dr. Mairal said, that while sitting here, we think we can do a lot. We tried giving these second opinions. We have these advisors from Stanford Children's Hospitals, UCSF, Boston. But over and over again, we realized that yes, the child can be saved, but where? So, and then the other thing we realized was the most important thing, that the awareness lacks. Even in the educated world, if people don't know that 1% of the world population is born with heart disease, think about the lower income areas, the global south, where this knowledge is just not there.
And on that note, I'd also just love to hear a bit more about the hospital that you have now launched over in Lucknow. How has that all been, and what have been some of the learning lessons with actually trying to operate that?
So like I said, we were giving second opinion. We touched almost 6,000 families. And that's when we were getting more and more knowledge that children can be saved. Where do we send the children? To tie to Dr. Mairal's statement, in the global north, let's say for US, 90% of the world's resources are for the 10% of the population. In US, we have 115 centers to treat 40,000 children, whereas in India, the largest population of children, logically because of the large population, 240,000 children are born with heart disease, and we have only 10 major centers. So that means for 10%, for 90% of the population, we're struggling with 10% of the resources. So that was the trigger to think about what to do. So the solution we've thought and we found was to create capacity, empower the human power, the faculty, build human capital, and that was one of the learnings. The other one was that India is changing very fast. The governments are in a nation building mode. When at the kind of audacious goals we had to serve the world, to serve the global south, at this point we have a mandate to set up 20 hospitals. We started the first one in Lucknow, and we reached out to first initially the central government, and then they guided us to connect with the state government because health is a state subject. And we were very surprised that the state was very receptive and they were ready to put in their money. We did not have to convince them that there is a need. They knew about it. All they needed was the conviction that the partner has the sincere will and the capacity to train their institution. So fast forward, we've partnered with an institute called SGPGI, Sanjay Gandhi Postgraduate Institute, in Lucknow, which is funded by government of UP, and commendable speed of execution. I mean, when we are drawing out plans, it looks very audacious, but when it actually is on ground, Dr. Mairal has visited, and we welcome you all to visit. Commendable speed of execution.
Excellent.
Can I add to that? Because I've seen the center, and this is mind-blowing. I mean, Stanford started partnering with Uttar Pradesh after the same visit that the Uttar Pradesh delegation had. And they also met with Saloni Heart Foundation. This is three years back. And within those 3 years, this foundation, this little foundation, has not only created Saloni Heart Center, but they have gotten large numbers of positions created. They have a whole floor dedicated. They have inaugurated the center, and children are being treated there. I have never seen a government institution and a government, state government, move as quickly as they have. So kudos to the state government and that institution, amazing leadership, but kudos to Milli and Himanshu and rest of the Saloni Heart Foundation team, small team, that has accomplished that. I mean, really very, very impressive. Those of you who are from North India should absolutely go and visit. Because in entire North India, very little capacity of this kind exists. So, and I come from North Central India, so I personally feel very grateful that you've done that. Thank you.
Wow, that is all just so excellent. Let's now shift over to you, Anurag. So you have obviously built this AI-enabled microscope. What is it being used for? Where all is it being used, and what do you see as the next step with all of that?
Awesome. Yeah, firstly, thank you, Dr. Mairal, and everyone for organizing this. So this is related to Octopi, which is the AI-powered platform that you're talking about. This is mostly focused on diagnostics, and our aim is to decentralize diagnostics and take diagnostics to the most rural places, the primary healthcare centers where maybe the only diagnostic equipment is a microscope and there's one person serving it. So that's our goal. But to add another layer to that, this is done by AI-powered detection. So it's to also empower any clinician to actually make and build these AI models. So we have been focusing our energies on like malaria, sickle cell disease, and there's only a few things that we as a core team can tackle. But we've built this platform, this automated platform, microscopy platform that does the automation. So there's automation on the slide scanning, but also automation on the disease detection. So you can empower even community healthcare workers to do advanced diagnostics where you would normally need a very, very highly trained microscopist to do. So this has an enormous potential for task shifting because there is currently almost 1 million, shortage of around 1 million diagnostic staff right now. And a tool like this can empower a lot of clinicians, but also anyone that wants to research and develop these. So we're trying to, so over the past almost a decade when Manu started this project, and now it's spin off as a company in Sefla. Over this decade, we've been primarily focusing on a few key diseases, and we've been co-developing this with partners in Africa, in Asia, because the expertise and the disease burden actually is there. So we can't be building them by ourselves. So we have followed this co-development model from the get-go, but we want to take this a step further where this co-development can be done by anyone. We're thinking of this like an app store for diagnostics. Think of it like we have this platform similar to like an iPhone or any other phone, but then anyone can be a developer of the app. And this is very important for scaling technologies like these because, again, with our core team would have very limited bandwidth on which diseases we want to focus on, but then we want to be able to empower basically anyone to make AI models for their diseases that concerns their communities. And we're basically flipping the script because conventionally how AI diagnostics works is there is a top-down approach. So let's say the Gates Foundation has these priority diseases, That's where most of the funding goes, that's where most of the AI research goes, and that's where the data goes. But then the data is coming from LMICs, right? This is an extractive model where people are going to LMICs for clinical studies, extracting the data, making AI models, and then giving them back. What we want to do is try to flip that script and make people in the global south co-creators of this technology. Yeah.
And what are examples that you, Anurag ji, are seeing in either here or in India that use AI to, on much of that exact same note, make it easier to automate the overall management or the diagnosis of different medical diseases? How much investment are you seeing institutions like Stanford and others are actually having to ensure that these AI-enabled tools are able to reach the lowest resource areas?
Yeah, great question, Bhao. And I just want to give kudos to Manu Prakash. How many of you know Manu Prakash? He is my colleague here at Stanford, and he's been working on frugal innovation, frugal science for a pretty long time and phenomenally well. And Pranav and he have done this diagnostic tool, and it really talks about the reimagining health script that we are talking about, how bringing more care closer to home. And one of the starting point for care is diagnostics. So if you don't know what the disease is, you can't treat it. So you fix what the problems that exist and that you find. So that's actually really important. And then top-down versus bottom-up is a very important point as well. If the priorities are set by the local communities, and local communities are partners in that, in developing those tools, using those tools, adoption of those tools will also be higher. So that's a really important model and sort of aligns with what you're doing, what Stanford Biodesign is doing in India and Africa elsewhere. In terms of AI, I personally feel that AI enabling healthcare access for LMICs, for 5 million people in the world who don't have meaningful access to healthcare, is going to be a game-changing sort of approach. And we are already seeing Stanford Biodesign's founders forum, which advises innovators coming out of India. We are already seeing a very large portion of those technologies that are being developed in India, for India's needs, India's Indian data, but they're finding their way to the rest of the world, including in the US. There are many of them actually coming back to the US, coming to the US to address the needs here. So it's a really remarkable time and place, and I think Dr. Milli talked about in her comments as well.
I'll just ask the last question to Milli ji, and then if we have any additional time, we'll also open it up. Where do you see sort of, you are obviously working very specifically in the heart surgery space. Do you think a similar model will work in, many of the other multi-specialty, highly expensive areas of healthcare in India? What are maybe some unique advantages that you had going into specifically solving the issue in heart surgery that may actually have useful insights for other specialties as well?
Absolutely. So ours is a very classic model of US-India partnership, academia, industry partnership, and public-private partnership. What we learned is that even while we really appreciate all the innovations and AI and technology, everything is happening, but what deters treatment in any specialty is not the technology but the front door. Getting to that front door is the most important thing. So our learning is that first step is awareness. And as between India and US corridor, yes, any area of specialty can succeed as partnership. We as US institutions have to understand that a partnership has to be equal. We can't be experts and they can't be needy. So we also have a lot of learning when we visit there, when we are interacting. It's a two-way partnership. And Government of India, again, I always say kudos to them. We are in a golden era. The government is ready and very receptive. Recently, at one of the other forums, I heard that even VCs are getting funded by Government of India. So, so this is an opportune time, and there's a lot of transparency, speed of execution. So anybody who's willing, in any specialty, there's a lot of support on both sides.
Great. If we have any questions, we can try and take them now.
Hi. Actually, I just want to call upon Amit Bhatnagarji, who is working on the ground in India, developing an amazing technology platform. You know, while you ask the question, can you talk a little bit about the work you do, maybe 30 seconds, a minute?
So I'm Amit Bhatnagar. So we have invented a rural healthcare model clinic on a bike, which has a capacity of doing 200 parameter of diagnostic tests, which is liver, kidney function test, glucose, hemoglobin, even cervical cancer screening. And in rural areas, ladies, they get urine infection, but they don't know what kind of infection it is. So 200 parameter of diagnostic right at the doorstep. Our innovation is used by Indian Army, more than 100 foundations. But combined with our skilling program, which is we are able to design after 8 years of research, we decrease the skilling program from 4 years to 4 months. So now we can create a rural youth with a skill in hand, where he can deliver KFT, LFT with a good accuracy. So Medanta, we done a project with Medanta Hospital, and they got so impressed that they have invested with us the top clinician of Medanta Hospital. So John Hopkins with PwC, they validated our technology, and then I was invited as a speaker in Washington DC office, because our initiative had triggered 3 impacts. One is last mile care, second is the youth empowerment, and third one is the carbon net zero. So the question I was about to ask you is...
Can I make just one correction? First of all, round of applause for him. And there's one other gentleman here from India who's developing amazing technologies and incubating them. Mr. Gare, Dr. Gare, can you please stand up? And congratulations for that. So amazing folks that are changing innovation game on the ground. I'll just take one correction. Can we all agree to not use the word last mile? Can we use first mile? Okay. I'll tell you why. Because last mile means that institution is the center and community is the last in the care. Yeah. I think community should be the first in care. So, please, I didn't mean to interrupt your question.
That's fine. So my question is, we do talk about, medtech innovations. But what I clearly felt after spending 15 years understanding the rural healthcare challenge is till the moment we have sustainability in place, somewhere we are losing the whole concept of delivering of sustainable care. Right now, when these first mile there, the model they are running is the big MMUs, which are big vehicles, 50 lakh capex plus 5-year OPEX is like 2.5 crore rupees. The problem with the charitable model is it's salary-based employees. So, they do only glucose, hemoglobin. Even having all the medical innovation with them, they are not delivering the whole care. So you have to do the model innovation also, so that there is a motivation among the people in the rural areas so that they are delivering extended care which is needed on the ground. But then we also need to understand that we do not have to rush for automation, because somewhere catching up with the Western world, we are only trying to catch up with the automation thing. But with the developing countries, the biggest resource they had is their manpower. So if we engage them and enable them with that care, so this become a viable, sustainable model which is going to create employment and create first mile care
Sir,
to the people on ground.
Yeah, so if we would, what is the exact question?
Yeah, so
all to understand?
The question is, so how do you see that we need to club in with that medtech innovation is the scaling innovation and the model innovation of the delivery model?
Great, thank you.
Yeah, I think that comment stands by itself. You're absolutely right. I think, especially in LMIC settings, technology innovation is not enough. So I'm an engineer by training. I do technology innovation for a living, and I've come to the realization after spending time in global health that unless you have innovation in care delivery, innovation in training, innovation in business model, innovation in incentives, you're not going to create the impact. So you're spot on. So that comment actually stands by itself. Thanks.
Thank you.
I totally agree. I think we're still at an early stage. You've done much more than what we have, I think. But all of our co-development has been, like I said, like in partnership with people in LMICs. And then these are people that have very deep roots, like clinical roots. And I think in our deployment model would be engaging with these partners. Like that's the only way that it can be sustainable. Yeah.
Great. If there's one more question, we're happy to. Okay, actually, with that, we will now have to end it, but let's give a huge round of applause here. Thank you. Thank you.